Welcome to our second event in a new three-part virtual series hosted by the Harvard Global Health Institute and the Edmund J. Safra Center for Ethics. This is our second event entitled Decarceration as a Public Health Strategy, Stopping the Spread of COVID-19. My name is Daisy Winner, and I oversee the Harvard Global Health Institute's work on systems of oppression. So as we're all probably familiar, COVID-19 has torn through prisons, jails, and detention centers around the world. But this doesn't really come as a surprise, considering that incarceration and carceral practices have been long known to harm health of those inside and the surrounding communities. In response to the pandemic, decarceration and reentry efforts have been taking place around the world. Today, we're going to explore those efforts and what they've looked like, how they've gone, and how decarceration might fit into broader strategies around improving health outcomes. So before we get started, I have just a few notes. This video is being recorded through Zoom and is going to be made available on the HJHI website and our YouTube channel shortly after. We've also embedded the chat function, which is going to be monitored and overseen by my colleague Ellie. And if you have something to say, just make sure that you send the message recipient as everyone. And we'd like to invite everyone to share where they're calling in from today. So if you want to put that in the chat, that would be great. And so with that, let me introduce our speakers. Today, our moderator will be Dr. Raul Vanjani. He is the assistant professor of medicine at Brown University, where he practices medicine as a primary care physician. Prior to coming to Brown, he worked at San Quentin State Prison, where he provided primary care to individuals in the general and special needs population and on death row. In Providence, he oversees the Lifespan Transition Clinic, a multidisciplinary program that brings together community healthcare workers and healthcare providers to provide primary care and wraparound services to individuals transitioning from prison back into the community. Madhurima Dukana is the program head of the Prison Reforms Program based in India. In this capacity, she leads, manages, and develops initiative of the team in order to improve prison conditions, strengthen prison oversight mechanisms, strengthen pretrial decision-making, ensure access to prompt and legal aid, and effective legal aid for persons in custody, and protecting rights of vulnerable prisoners, including women, transgender people, and foreign nationals. She is a lawyer with LLM in criminal justice from the University of Nottingham, and she's been associated with CHRI since 2008. She's published numerous studies, reports, and resource materials on issues related to prisoners, legal aid, and the criminal justice system. So Dr. Lisa Pluglissi is the assistant professor of medicine at Yale University, where she also practices primary care and addiction medicine. She is the director of the Transitions Clinic New Haven, also a multidisciplinary clinic that is part of a national network of programs that focus on care of individuals who are returning into the community from incarceration. Her clinical practice includes treatment of addiction and hepatitis C in primary care, and she also oversees a medical legal partnership. She's developed specific skills in training, hiring and supervising community health workers, and directing interdisciplinary teams of physicians, middle-level providers, community health workers, research personnel, and legal colleagues around the work of clinical care and research to improve the health of people with recent incarceration. She is originally from New Haven and deeply committed to the community. Lisa received her undergraduate degree from Tufts, her medical degree from Albert Einstein College of Medicine, and she completed her medical training at Yale New Haven Hospital. And finally, Leslie Creel was released from federal prison in 2018. Since she was released, she has been on a mission to dismantle the carceral system and end incarceration for women and girls. Sadly, while incarcerated, Leslie endured the loss of her beloved daughter, Brianna, to gun violence. Turning her pain into purpose, Leslie utilized her lived experience and has become a fierce prison abolitionist and social justice advocate. You can find Leslie advocating for formerly incarcerated individuals and those with a criminal record to obtain sustainable, equitable housing. Through her creative soul, Leslie developed the model Hands-On Defense, which is designed to disrupt the screening criteria used by public housing authorities to determine if justice involved applicants merit housing. She is a Northeastern University alumni and 2020 and was part of the 2020 cohort of Columbia University Women Transcending Collective Leadership Institute. And she is dedicated to being a future leader in the movement to end incarceration of women and girls. So with that, I'll hand it over to Raul to take it away.
Thank you, Daisy. Thank you, everyone else, for joining us today. I'll start with a brief introduction, and then we'll move into the panel discussion. The COVID-19 pandemic has laid bare the social fault lines of societies. In the United States, COVID-19 has demonstrated yet again that ours is a society of tremendous inequality. This realization has surprised many Americans. However, for those of us who identify as abolitionists, individuals who seek to undo the hegemonic notion that prison and punishment more generally is the solution for social, economic, political, and behavioral problems, that social and economic inequality is a major proliferative vector of COVID-19 has not come as a surprise. This is not the first time the social forces underlying health have contributed to a public health emergency. Our country has been simultaneously battling another public health emergency, also fundamentally fueled by social and economic determinants, mass incarceration. The United States harbors approximately 1 out of every 4 incarcerated persons in the world, under the pretense of promising accountability for violence and crime. However, in reality, it's well known that the American criminal justice system is itself violent. A structurally violent entity, the criminal justice system targets racial and ethnic minorities, individuals who are poor, and individuals with disabilities. It does not, and has never been shown to, reduce violence in our society. Abolition seeks to accurately characterize our criminal justice system as violent and oppressive, and simultaneously illuminate a broader transformative vision that maximizes our collective well-being as a society. To that end, the abolitionist does not simply seek widespread decarceration, leaving scores of people in the street without a source of income and at exceptionally high risk of death. Rather, abolition places equal emphasis on closing prisons and building a society that invests in its people by providing jobs, housing, education, and importantly, healthcare, the elements necessary for a meaningful life that's free of violence and free of crime. Thus, the healthcare official who supports universal healthcare is, in a sense, an abolitionist. The politician who advocates for high-quality free public education is an abolitionist. The activist who protests in favor of a universal basic income and a strong social safety net is an abolitionist. The values and ideals from which these opinions stem prioritize the well-being of the collective over any one individual, and equality over profit. It's reasonable to presume that the individual who supports these policies would also support the complete transformation of a criminal justice system that devalues and dehumanizes the people entrenched within it. Yet there's a dissonance, as evidenced by the fact that scores of Americans recently celebrated the conviction of Derek Chauvin and Larry Nassar before him as justice served. Derek Chauvin will likely be handed a multi-decade sentence, and Larry Nassar was given the equivalent of a life sentence, with the judge declaring to his face, "I just signed your death warrant." There's no question that these two men committed horrific crimes, but that we as a society choose to celebrate the American criminal justice system in such circumstances signifies that most of us continue to subscribe to the hegemonic principle that prisons serve as the solution to social problems. As a society, this represents a conflict of conscience. If we can imagine a future in which all people have access to high-quality healthcare and education, why do we struggle to imagine and advocate for conditions that would humanize all people and reduce violence and crime. With this question in mind, let's revisit COVID-19 in the United States, where, eerily similar to mass incarceration, the United States has harbored approximately 1 out of every 4 cases in the world. Starting in March 2019, activists in the United States and globally began calling for prisons and jails to be decongested, arguing that due to overcrowding, lack of resources, and unhygienic conditions, correctional institutions served as so-called epidemiologic pumps, placing the people inside and the surrounding communities alike at heightened risk of COVID-19. Decarceration was thus framed as a public health strategy and received more attention by the media and policymakers than any time previously. Physicians and other healthcare professionals joined the call to decarcerate, writing articles and policy briefs explaining their rationale and advocating for the brisk release of people with less than 6 to 12 months left on their sentence or with nonviolent backgrounds. However, despite the best efforts of the medical, public health, and legal communities here in the United States, we now know that policymakers failed to reduce the populations of correctional institutions enough to slow down the spread of COVID-19. At the San Quentin State Prison in California, where I previously worked, there was a massive outbreak, during which scores of my former patients contracted COVID-19. For San Quentin, this was the second major outbreak in 5 years, having endured a Legionella outbreak in 2015. In Rhode Island, where I currently work, the spread of COVID-19 was so rampant in our unified prison and jail system that it caused immense tension between the medical director and the Department of Corrections, leading to the public resignation of the medical director in the midst of the pandemic. There are countless other examples like this throughout the country. Incarcerated people have contracted COVID-19 and died at a rate unparalleled in the general public. In April 2021, the Prison Policy Institute reported that the moderate drops in prison populations in 2020 were not the result of releases, but rather fewer admissions. In fact, most parole boards granted fewer paroles during 2020 as compared to 2019. As of December 2020, 19 prison systems were still at 90% capacity or greater. Moreover, many of the changes made during the pandemic to ease the burden on the denizens of correctional institutions, such as waived medical copays and free communication with families, have since been reversed. Despite immense pressure to decarcerate and stop putting incarcerated lives at risk, the status quo has largely remained intact, and in some arenas, such as the granting of parole, has in fact worsened. Momentum is being lost. To reinvigorate this movement, it's important to consider the forces that have resisted change in the face of profound loss and death. Mass incarceration and the prison industrial complex more broadly has deep roots that are nourished and fertilized by financial interests, racism, and a fundamental belief by the American people in retribution for individuals convicted of crimes. In order to accomplish meaningful change, these 3 core tenets of American society need to be addressed. Fortunately, abolitionists have been considering how to combat and overcome these forces for decades. It would, therefore, be prudent for our public health movement to join forces with and learn from the abolitionist movement, which has historically been led by Black women, many of whom came to abolition as a guiding framework after learning during the course of anti-violence work that transformative justice and not prisons were the answer to violence in their communities. An important guiding principle central to abolitionist work is the concept of non-reformist reform. In the words of abolitionist Mariam Kaba, non-reformist reforms are, quote, those measures that reduce the power of an oppressive system while illuminating the system's inability to solve the crises it creates. This type of reform considers all of the consequences, both negative and positive, of the measures being advocated, with a specific eye toward ensuring that the criminal justice system is not strengthened during the course of reform. As an example, there are numerous articles written by health officials over the past year calling for the release of people convicted of nonviolent crimes. Small concessions were made by many states, but the overall response across the country was to release fewer people on parole in 2020 as compared to 2019. Whenever the focus of our reform efforts is on the nonviolent offender, the notion that prison is a suitable destination for people who have been convicted of violent crimes is reified, and the incorrect assumption that people convicted of violent crimes cannot be changed is strengthened. And yet, what we know about the American criminal justice system is that almost everyone is released back into our society at some point. So what gives? As we move forward, let's consider being more deliberate in the partnerships we forge and the messaging we deliver. It's time for the public health and medical communities to reach out to local and national abolitionist organizations and to broaden our messaging from decarceration to abolition. The evidence is there. Now what we need is to radically reimagine the notion of justice and to put forth policy recommendations that equally prioritize the lives and health of all people. With that, I'd like to transition into our panel discussion, where I'm joined today by Madhurima from Calcutta, Lisa from New Haven, and Leslie from Boston. Welcome, Madhurima, Lisa, and Leslie, and thanks for joining us. So I'll start our panel discussion today with the basic question. And Madhurima, I'm hoping you can take a first stab at this question. Could you give us a global overview of what decarceration efforts have looked like during the COVID-19 pandemic across the world and in India more specifically?
Yeah. Hi everyone, and I'm glad to be here. I'm joining in from, I guess, pretty far away from where most of you are. So of the many things that the pandemic has brought about, one positive, if I may say so, has been the focus that it brought upon incarcerated populations. So prisoners who were generally forgotten somehow managed to get on the priority lists of governments worldwide. Several governments initiated something one had not heard of earlier, decarceration. It's usually, increase incarceration, send more people to prison. But now suddenly there was this whole cry about reducing prison populations. And probably for the first time, in recent years, an effort or a dedicated effort was at least made in some parts of the world to release people from prison. So a recent report by DLF Piper has estimated that between March, which is 2020, which is when it was declared a pandemic, and July, around 475,000 prisoners were released worldwide. So their report focused on 53 jurisdictions. And of those jurisdictions, they reported so many releases, in which the highest people released were from Iran, India, Iraq, Ethiopia, Indonesia. US didn't meet the criteria of the higher ones. Some of the states actually are listed in the states which release the least number of people. And I suppose that's in align with what Rahul you've talked about, how the pandemic has impacted prisoner populations in the US with little or no consideration for the release into the society as a measure. So these, of course, these are just figures. Official figures are not available in most parts of the world, so these numbers could actually be higher. But these are the figures we have for now. And it's been, the pandemic has been difficult for everyone, and for prisoners it's been even worse, and for prisoners' families it's been like maybe multiple times that, because there've been so many restrictions that have come about in terms of how it has played out for the prisoner. If you look at it from the criminal justice aspect of it as well, courts were closed, or the hearings suspended, or they were doing virtual hearings in a world where half the prisoners probably don't even understand what is virtual, what's a computer, how does this work. And there's absolutely no visitation happening. You can't meet your families, you can't speak to your family members, you're not able to meet your lawyers. So the kind of restrictions that the pandemic brought about were also unreasonable, and also unmonitored to a certain extent. When your monitoring bodies are not able to visit prisons, then we can only imagine what would have been happening inside the prisons. You could be we heard of stories of people being put in isolation wards. It was no short of solitary confinement, I'm sure, for a lot of people. So in this world that we have come about, where things have been just not normal in the past year or 2 years, the decarceration efforts was certainly a silver lining of sorts. And in India, the decarceration efforts were prompted by a judicial order. The Supreme Court of India, which is the apex court, it on its own motion, it took cognizance of the concerns of the spread of the virus inside prisons. Very early on in March, they actually set out an order directing for the release, or they set out a mechanism on how to end up releasing prisoners, which primarily comprised of having a high-powered committee in every state. So India has 36 states and union territories, and a high-powered committee comprising of judicial officers and prison officers was constituted, which was supposed to recommend the categories under which prisoners could be released. And just to give a better context, India has around 1,350 prisons, and our prisoner population is around 0.5 million. However, that's just the population on any given day, but over a course of a year, around 1.8 million prisoners are admitted to a prison, and the prison occupancy rates are somewhere around 118.5%. However, these are average figures. So in some states or some prisons, this can actually go to 150 or 200% even. And unsentenced prisoners, which are around 70% of our population, is a huge concern. And there has been, of course, a lot of discussion around that. So we studied, I work for an organization called the Commonwealth Human Rights Initiative, and we studied the decarceration effort that happened from March to June 2020. And surprisingly, we were actually surprised in a pleasant way, because it indicated that there was the prison population came down by around 10.42% in that period, which is quite substantive. And even overcrowding also came down in several parts of the country. And there was a lot of having the high-powered committees where they were very active. It also meant there was a lot more focus on prisons. We also did our efforts. We made a lot of checklists and monitoring checklists, trying to motivate and advocate for stronger monitoring of prisons during this period, given the kind of restrictions that were going about. And a lot of the high-powered committees actually not only took care of decarceration, but they also looked at it from the other angle of a public health emergency, and looking at what means were there, how prisoners were being treated, how they were being isolated, and the entire process of it was also considered. So, yeah.
Madhurima, thank you so much. One quick follow-up question. You mentioned that the prison population in India decreased by approximately 10% between March 2020 and June 2020. Are you able to characterize the individuals who were released? Are there any characteristics that they hold in common? How did India go about making the decision around whom to release?
So not really. It's very difficult to there was no one group that was released, if that's what you were meaning, because given that India spread across so many states, and every high-powered committee had its own idea or discretion on deciding who they were going to release. So some of the states were very liberal. They actually let out much more, like in certain cases, which others did not even consider. Some of the prisons considered senior citizens and people with comorbidities, etc., given the pandemic, and where it was likely to strike more. Some prisons, some states actually just said, okay, we're not going to release anyone. We're just going to shift people around, and that's about it. So it's difficult to put a pin on which kind of people, but if people can go to our report, which is on our website, which kind of talks about every state and what categories of people each state had released. So that kind of gives a sense of what the groups that were more likely to be released. But yeah, generally it was less than like 7 years punishment. That kind of group was more likely to be released during this period.
Thank you, Madhurima. And staying on that topic of states, considering that we have two people living in the United States here, one from Massachusetts and one from Connecticut, starting with Leslie. Leslie, might you be able to tell us a little bit about what decarceration efforts have looked like in Massachusetts since March 2020?
Sure. Thank you, Raul, and thank you for having me. My name is Leslie Credo. I'm the Executive Director of Justice for Housing. I'm also a member of Families for Justice's Healing and the National Council for Incarcerated and Formerly Incarcerated Women and Girls. From the beginning, the DOC and the BOP knew they could not manage the COVID pandemic inside prisons. Although they told the public that they had it under control and they were equipped to manage the pandemic. But us prison advocates, we knew differently. Commissioner Michi claimed that the long-term lockdown policy was for safeties, but in reality, it was just 18 months solitary confinement. Once they were given the green light to lock everyone down, they ran with it. And they did whatever they could do to keep it that way. It made their jobs easier to keep people locked in a cell 23 hours a day. I give them an F. Not only did they mismanage it, they violated everybody's human basic rights. The DOC and the BOP, they kept flip-flopping. When Attorney General Barr put in the order to have people released from federal, those families and efforts from attorneys from the National Council began putting in motions for compassionate release home confinement. And each jail individually ignored their policy that came down from the Attorney General's office. And families that thought their loved ones were coming home were suddenly faced with the reality that that was not going to occur. There was so many ways that Massachusetts could have handled this pandemic. And like Mahima said, United States was like rated, in the top bottom for releases. So New Jersey, California, and Oregon, Kentucky, they afforded some releases that we could have did here. They did commutations and releases of sentences of nonviolent crimes, where 1,500 to 3,000 people could have been released in Massachusetts. But our efforts to get our governor to do this was ignored. Governor Baker has not granted clemency in his whole term since he's been in office, nor did his predecessor, Deval Patrick. Prisoner Legal Services and Families for Justice's Healing sued the DOC and the Parole Board and Governor Baker unsuccessfully to decarcerate prisons. We wrote a letter to Governor Baker about the public health travesty inside in January. And to no avail, no prisoners were released. State Rep Lindsay Sabatota, she proposed an emergency bill calling for the prisons to release on a case-by-case basis medically compromised individuals, as well as those being held in pretrial with short sentences less than 6 months, and people incarcerated for parole violations, those who have technical violations for substance abuse or fines. Um, it could have decreased the population by 25%. Uh, Instead, over 256 people have died in Massachusetts prisons to date. That bill was called an act regarding decarceration of COVID-19. Um, a lot of efforts were made to decarcerate, and the state refused SJC rulings back to back. What the state did was take credit for the low numbers of incarceration as the pandemic was going. The rates of incarceration was going down. But the only reason why it was going down is because the court shut down. And so people weren't being brought into custody, they weren't being held. And then people's sentences were coming to an end. So people were getting released and no people were going in. Plus the mass bail fund did a massive job of raising their bail limit, and they bailed people up to $5,000 during the pandemic. So we were able to get a lot of people released through those efforts. But the DOC, of course, took credit for the low numbers, claiming that they were releasing during COVID, where actually all the motions that were filed, only like 1% of them were granted. Also, Congresswoman Ayanna Pressley, along with lawmakers, sent a letter condemning unsanitary conditions behind bars. In November, December, we had an extensive outbreak of COVID where people that we filed compassionate relief motions for previously were denied. And so what the DOC did was when those incarcerated individuals got sick and they were hospitalized and on their deathbed, I received a phone call from someone I correspond with inside saying that a correctional officer came to his cell and bragged that incarcerated person Milton Rice was granted COVID relief, and he's a lifer, right? He had a natural life sentence. He was previously denied to be released on COVID, but on his deathbed, when the DOC knew that he was not going to make it, they granted him COVID relief and released him. And so they did this to forge the numbers so that when he died, they could say he didn't die in DOC custody. And so they did this for numerous people who were on their deathbeds. They granted them COVID relief, and then they died the next day. And so just to say that people didn't die in DOC custody, they were trying to make the numbers go down. So this is what has happened in Massachusetts. We failed our incarcerated community, and it cost lives.
Thank you, Leslie, for painting that picture of Massachusetts's criminal justice system over the past year. It's hard to hear you speak, and I can hear the pain behind your voice. And so I appreciate you sharing that history. Lisa, can you compare and contrast the Connecticut experience with Massachusetts? And I assume it's somewhat similar, but could you give us a little bit of history from Connecticut, if you don't mind?
Sure. Yeah. Thank you again for having me. It's a real pleasure to be here with these panelists and yourselves talking about this really important issue. I think, though, I'll shift a little more to the health side, if that's okay with you. So Connecticut, too, was like many states where, as most of you have already mentioned, really had court shut down, most people weren't going in. You know, there was a rapid move, I will say, to get people out who were sort of semi-close to getting out anyways. And I very much supported that effort. You know, we, right from the very, you know, week the shutdown happened, we're saying like, we've got to get people out now. I think anyone who's been incarcerated themselves, does work with incarcerated people, like knew what it was going to end up looking like inside and how much more infectious this this viral process would be in systems that were built years ago that didn't have the right ventilation, which are already crowded spaces that are not built around sanitation and infection control. And, you know, I'll say, and, you know, from our experience, we ended up just mounting a community effort where we reached in and said, like, we have to help you guys get people out. And like Leslie's, you know, in the housing sector, I think that we can hopefully agree that when you talk about release of people from prison and jail, even non-COVID times, the needs are inextricably linked. So the needs for housing, the needs for access to healthcare and insurance, food, employment, you cannot parse them apart. There are very few people who don't need some, you know, some mixture of those things. And it provided us an opportunity to see more than ever, like, you have to be working together on the outside to actually help deliver what people need when they come home. So that turned into a couple times weekly call with the Connecticut Coalition to End Homelessness and other community agencies, as well as ourselves, Transitions Clinic. We just said, like, you send someone home with a medical problem, just tell me where they're going and we'll find them a clinic. We'll find them telemedicine, we'll provide the telemedicine ourselves. Like, we gotta be doing different type of stuff here, right? And so I think it's an example of, but none of this is really COVID, right? Like, it is in that there was an urgency and it was like the house was already on fire, right? And you're mounting everybody to come save it. But these are things that have been needed and could have been imagined and developed really even before COVID, right? The need to decarcerate is not unique to COVID. I think we should be really clear on that. The need to decarcerate has existed for the past over 20 years and longer than that. The urgency to decarcerate is what came with COVID. And like you said, like, none of these changes are really permanent. It's not like policies were fundamentally changed in terms of who goes in most places. We have, you know, some states that have ended cash bail and jurisdictions that have, but beyond that, very little has been done to fundamentally change how we perceive people, what we consider legal and illegal, and who we incarcerate. And so I think we have to be real wary and not say, like, oh, good, there was this big decarceration. Like, it's just going to go right back up. And that's what I think we all know to be true. And I think that another real challenge to decarceration during COVID and before has been that we must acknowledge, even though we have a vision of sort of young people being incarcerated, and that's true to some extent in jails, the prison population is increasingly a really aging population with multiple health problems. And you can't, like, you know, let's think about it from the community lens. Like, you're in a hospital. You can't take somebody who's newly on dialysis and has catheters in them and all this stuff and just say, like, okay, well, today's the day you're going home. That just doesn't work. It never ends well. And I've seen it happen, you know, for dramatic reasons, but that's not good, right? And the same is not good from, you know, from the carceral to the community setting, just, you know, a real rapid discharge without planning. Like, how are you sending someone home who's on dialysis? We have even some federal prisons where everyone in that prison is on dialysis. How are you sending that person home without serious forethought, planning, collaboration with the community? Like this takes work, it takes insurance, it takes community people who will be funded to do the planning and the work, and correctional people that have to be funded to to make these connections. We're awful at that. And I think we have to be real careful about who we blame, because we can just blame the correctional system, but I work in the community. We have to take the real onus on ourselves too, that we've allowed this false dichotomous system to exist for decades, if not longer, really always, right? It's like what happens behind bars, well, that's that thing, right? And the community health system in the US and really in many places has failed to own that they too are, that people who are incarcerated are also community members still. And so their healthcare while they're incarcerated ought to be, monitored by community people, measured, valid, questioned, checked, like credentialed, all those important things. And that's something we've failed to do for ages. And I think it causes barriers to rapidly decarcerate during the next pandemic, right? But in the meantime, there are things we've got to do to change that system so that there are not these two siloed scenarios where it's really kind of crazy, right? It still blows my mind whenever I talk about it, but it's like a black box. Like in the community, they just don't even ask you. Most community physicians don't know how to call in. Who would they ever call to? What power do they even have to change what happens health-wise behind bars? Like there is just such a large wall erected between these two health systems. And it's erroneous. I mean, it's perpetuated by funding inequities, right? Like the inmate exclusion in the 1965 Social Security Act with Medicare, Medicaid. But these are things that we have to work to change if we'll ever be able to like truly decarcerate to a meaningful level because or not because of COVID-19, just because we ought to regardless. And another example of that is our real deep underuse of compassionate release mechanisms. Like Leslie was saying, these are people who were getting released on their deathbed. Well, we know that once you're probably, there's a lot of ways to put it, but there are people who are younger than that and less sick than that who could also be released via compassionate release mechanisms. If you look at the changes in compassionate release guidance at the federal level, it's much more emergingly in line with the geriatrics literature, which is like, if you can't walk well and you can't go to the bathroom that well on your own, like, your risk of coming out and recidivating is probably exceedingly low, regardless of what type of crime, regardless of violent or non-violent. If you need a wheelchair to get around, like, let's agree that this is a person who belongs in the community. And these are mechanisms that are dramatically underutilized, really utilized minimally, and ought to be, like, I think a place for real push and growth and development is how to use these mechanisms more broadly to get aging incarcerated people out now and going forward.
Thank you, Lisa. Mother Rima, Lisa and Leslie have spoken to some of the challenges around accommodating individuals who transition from prison back into society. And here in the United States, that's the focus of a lot of discussion and work. In particular, a physician and sociologist named Carolyn Sufrin followed pregnant women in San Francisco who had histories of being detained in the San Francisco jail. And interestingly, what she found from her ethnographic fieldwork was that at times, the social support network, social service systems in the San Francisco community were so poor that these women sometimes felt more safe and cared for inside the jail. And so that speaks to the American social service system and the disrepair it's currently in. And so I'm wondering if you could tell us a little bit about the transition process back into the community in India and what that looks like for people, considering the unique family structure in India, culture, social service system, etc.
So, just to respond shortly, I believe in India it's even more difficult to, once you're released, to be reintegrated into the society, because we really don't have, or we haven't spent enough focus or priority in rehabilitation of released prisoners. Though all our policies talk about it, all the prison reform committees have talked about it, everywhere we've started to say that the Indian system is about rehabilitation. But in practice, there's not much that is probably done. There are efforts. There are a lot of prison heads who focus on recreation, on vocational training, etc., to kind of enable prisoners to have an earning. Like, one of the biggest things is, when you get out, is how do you, look for money? How do you get something, a decent work? What skills do you have? So there's been effort around building those skills. Different states have tried different ways. Some teach theater, some teach, say, carpentry, some are doing some oil making or bakery or something or the other, and there are ways of trying to find people livelihoods when they get out. But still, there's no hand holding process that is available, which means that once you're out that door, you are alone, and you have to, fend your way, beat through the stigma of being incarcerated, which again, I think no matter where you are in the world, is a huge stigma. Even in cases where you were not convicted, or you were acquitted, the stigma follows you around everywhere, especially in the society, and especially in a society here which is so deep rooted or linked together. These stigmas also exist in a much higher and bigger form. Not to say that, every family probably stigmatizes, but I guess of the stories we hear about or what we read about, they all indicate the difficulties of getting back to the society. And the pandemic, the releases so the decarceration happened, it was the same time as the nationwide lockdown. So essentially, there were prisoners who were left out, released, had no means of going back home. They could not find the travel or the transport. And some prisons did take the initiative to arrange for local cars or conveyances, etc. But that's not true for all the prisons across the country. And there were actually instances where prisoners refused. They said they're better off in the prison than outside, because how do you go out in a lockdown, and how do you support yourself? What do you do? Where do you get the basic essentials are not available to you? And here again, the stigma would play, because ration kits, etc., everything is distributed, but prisoners often don't really qualify as, somebody that a lot of people don't really empathize with the plight of a prisoner or their family, right? So
Thank you, Madhurima. And Leslie, Madhurima concludes her comments in that section by talking about how people don't tend to empathize with the plight of the formerly incarcerated or currently incarcerated person. And you echoed that in your comments. And I wonder, Leslie, if you had the ear of the governor of Massachusetts, understanding that our public health plea or response to our public health movement to push for decarceration has not been quite as successful as we've wanted it to be here in the United States. If you had the ear of the governor of Massachusetts, what might you say to convince them of the importance of decarceration and abolition more generally? How do we change that sense among people of, or how do we increase the importance of the lives of people who are incarcerated in our society's minds?
Sure. So here in Massachusetts, we have a movement to end incarceration of women and girls. and what different looks like in our communities, right? And so we're creating a model of what that contains. And that's getting to the root causes of incarceration. Incarceration in our community is usually from poverty, substance abuse, mental health, lack of housing, and um, creating, getting to the root causes by creating a community where we're able to house, right? Housing is one of the root causes that leads to a person's incarceration. And so before Justice for Housing was founded, there really was no other organization like mine that dealt with housing discrimination of those with convictions, or the stigma and the barriers that those face upon release. And um, creating models like New Beginnings Reentry Services, which has a reentry home for women who are coming home that provides education, partnerships with universities and job training, and basic healing from trauma. You know, I'm a formerly incarcerated woman. I was released from prison, federal prison 2 years ago. And so it's those who have convictions on their record are capable of being employed, housed. And so we have to change that narrative, and we have to show them exactly what we're capable of and what different looks like in our communities. And how we do that is by investing in our community. There is no resources coming into communities who are the most incarcerated corridors in Massachusetts. So by depriving communities of color without resources, that causes a high rate of incarceration. So I'd say to the governor, we need more resources in our community. We need to fund local community organizations like the National Council, like Families for Justice is Healing, like Justice for Housing and New Beginnings, who are working on these issues, feet on the ground, and doing the grassroots movement work to end this cycle in our community. And we don't get enough. We don't get any, any support from our government or our city. And so this is what it's needed to achieve this goal. And basically, we can create a community where we can end incarceration of women, and we can start getting to the root causes to stop people from going in and out of prison by funding communities of color and other communities who are deprived resources.
So if the governor of Massachusetts is listening, please hear Leslie's call for housing and for funding of community organizations that are doing this important work, both here and globally. Leslie, right now, we are in a period that's unique in American history in that many states have bought or leased local hotels in order to house people experiencing homelessness who need to quarantine or isolate. And with a surplus of money that's come into states, numerous states, California being one of them, have decided to take this to the next level by buying hotel properties and converting them into permanent housing for people experiencing homelessness. And so it feels like these possibilities, this is all within the realm of possibility now. It's just about the will of our politicians and policymakers. Lisa, we had a question come in from one of the audience members that asks, what types of things can we as community members be doing to help individuals being released from incarceration access healthcare and other needed resources? How might we play an active role?
Well, that's a great question. I think it depends like in what space you find yourself and what your passion is, but there's lots of things we can do. I mean, I'll speak first from the healthcare side. So it takes, to some extent, healthcare transformation, but it's so doable. It takes building a health, like there is discrimination at the health system level. That has been shown. There was a study out of Canada, a country with universal health care. So access to insurance wasn't the problem. And you were half as likely to get a new primary care appointment if you disclosed you were coming home from prison. That is deep, right? That is just not surprising. No one's, fainting and falling over shocked, but it's deep, right? So I think those on the call who are in the health system, like it takes really examining that, acknowledging our role. We have the levels of barriers are so many, right? It's where you can live with whatever record you have and what programs you have to do that you have to pay to do, and then probation or parole limitations. And then you find your way to the health system. So people almost universally say health is at the bottom of their list when you ask them what are their priorities when they're leaving prison and jail. Like it's just so low because the other things feel so urgent, of course. Yeah, I always try to remind people in the Attica uprising in the early 70s, access to healthcare was #2 on their list of demands. They demanded access to reasonable healthcare, not run by other incarcerated people who weren't medical professionals. And so I think there's a real truth there, which is that it is important to people, but it just feels low on the list because we're forcing all these other immediate demands, right? It's like going into like a wave pool or something. Like when you have all those waves coming at you, you just have to try to stay alive. Never mind kind of the excitement of seeing family members or the other happy things, right? That you just want to do. Health falls down, but then we erect a barrier right at the healthcare door that makes it twice as hard to even get in. And so I think those in the health system have to really think deep about how to undo that. That takes hiring, in my opinion, it previously incarcerated people into the health system as nurses, CNAs, community health workers, directors, all the way up to the top. The way that you change a system is sometimes you have to break it down. And part of that is also eliminating barriers at hiring and health. Health systems are the largest employers in most communities, in many communities, I should say, but in across the country, health systems are massive employers. And we have to change hiring barriers to hiring people who have a record, because once you hire all these people in, the ethos of the organization changes to become more welcoming, understanding, accepting, inviting, like bringing people in instead of just letting them try to knock down the door. I think that's one way to look at it, all the way from HR down to the people who are working in the health system, changing their practices and how they treat patients. But it's really a system problem. It's not an individual person problem per se. And then I think it takes like a whole lot more cooperation than we ever do. And so, that means like we're always, in my opinion, so used to looking at the problem, like, okay, right now you're homeless, so like, let's try to fix that. And yes, you need to fix that. But what about looking at someone over their lifespan and looking to create wellness in their life, happiness, joy, productivity, like the good stuff? And that takes investing in people the whole life through. So not just when there's a major catastrophic drama, right? Or something terrible, even worse. There are programs that are evidence-based that exist that work. It takes investing in pregnant mothers, and they themselves and their children end up doing better and not getting in. You prevent incident incarceration. So that's primary prevention. It takes schooling. And so people in the school system, the education system on the line, thinking about changing schooling practices to be welcoming of students of families, of, all of that stuff. And then moving on, education, like Leslie mentioned, like access to a college degree, whether you're in or you're out, or it starts in and finishes when you come home, that changes people's lives because it changes earning potential and your ability to A, contribute, but B, care for yourself. And it's an evidence-based practice. People do better. And so it takes all of that stuff. And access to healthcare is another evidence-based, access to primary care is an evidence-based intervention that prevents further incarceration and improves health outcomes. So I think there's many sectors in which we can think to invest, but they have to go together. It's not like just primary care fixes everything. Of course it doesn't, right? I would sound crazy if I said it did. And then the last one is real stigma in the community. So Madarima mentioned stigma for people who use drugs, getting out and in their families. I have a colleague from Yale who runs a program in Malaysia in the prison system, and there too, releasing people who have had substance problems is a real stigma on the family. Many people won't be accepted back into their family. I think that's just universal. Let's agree that in most places around the world, that is the case, actually. It's surely true here in the US as well. And we have to do deep work to undo that and to embrace people, treat substance use as what it is, which is a medical, chronic, relapsing medical condition that for which there's evidence-based treatment as well.
Thank you, Lisa. That was incredibly well put and hopefully useful for many of the audience members on the call. We have about a minute and a half left. And so Madarima and Leslie, I wonder if you might be able to bring us home with approximately 30 seconds each. Could you give us a sense of how you believe we should consider people convicted of violent versus non-violent crimes in our decarceration efforts going forward? Madarima, if we could start with you.
Yeah, so an interesting question, and I take a very different view of when we talk about violent versus non-violent offenders. And for me, decarceration efforts are more about a kind of a rights-based or a legal provision-based release, and not about pitting one against the other, because I believe that certain non-violent crimes can also cause severe mental harm or mental stress or trauma and to the victim. So if I look at it from a victim's point of view, we're not really in a position where we can say that one is lesser than the other. So for me, decarceration is about looking at people irrespective of what they've committed. Look at them, look at their offenses, see where a probable case or a liberal bail or a parole policy can be applied, and apply it. And not to think about okay, he did this or she did that, and thus it shouldn't be like that. This is what the circumstances are, these are what the provisions are, this is what makes a favorable case of release, and henceforth the release should happen. And we would have, and again, like, yeah, decarceration should be, of course, more permanent in nature and not like the temporary sorts that we're seeing.
Thank you. And Leslie, the final word is yours.
Well, for me, I'm a survivor. My daughter was murdered, and so, it's people ask me, what is my views on somebody who commits a crime of violence. So, I say to this, people with violent crimes, they're coming home to our communities one day. They're going to be your neighbor someday. They are getting out of prison. Not everybody has a life sentence. And so I say that we have to prepare them, right? Like I said, get to the root causes of incarceration and deal with those issues to prevent violence in our community. And so, like I said, bringing in those resources to address those issues that create that type of violence is key to ending that cycle. And I can't stress anymore how that is so important to preventing incarceration and preventing any type of violence or crime committed is providing resources and making sure that our community gets mental health, trauma-informed care, whatever we have to do to keep our community safe.
Thank you so much, Leslie. That's a beautiful way to end this panel discussion. This notion that let's invest in our communities and our society to build everybody up so that we can work against violence and crime in a way that's organic and from the bottom up. With that, I'll turn it back over to Daisy to help us conclude.
Great. Thank you so much, Raul. And thank you to all of our panelists who joined us today. I thought that that was just like such an insightful conversation to be able to pair like the information that we need to harness action and really catalyze the action to support the communities that those that are incarcerated are absolutely a part of. So thank you for that. And thank you for everyone who joined our second webinar in our series. And be sure to check out the HGHI website and our social channels for the announcement of our third panel upcoming in the next couple of months. And yes, thank you again to everyone for joining us, and have a wonderful afternoon or evening wherever you are. So thank you.